Hi, this is my presentation on refugees and PTSD. So here I'll be going over treatment guidelines and specific treatments used for PTSD and in some specifics, PTSD in refugees. So what are the best treatment options for this disorder and what is the best fit for refugees? Okay, most of the most of the therapies that we'll be looking at are under the umbrella term of trauma-focused psychotherapy. These include a lot of cognitive behavioral therapies, or behavioral strategies. This includes emotional identifying emotional processes via repeated reliving or exposures of the therapy, then restructuring this kind of maladaptive evaluation of the trauma, oneself, and the environment. Together with restructuring these maladaptive assessments, we can see improvement of PTSD symptoms. Okay, so the next four treatments that I'll be showing are from the APA guidelines for treatments of PTSD. These aren't specific to refugees, but these are the top four treatments overall, including for refugees. So first, we'll look at cognitive behavioral therapy. Cognitive behavioral therapy focuses on the relationships among thoughts, feelings, behaviors, which target current problems and symptoms, and focuses on changing patterns of behaviors, thoughts, and feelings that lead to difficulties in functioning. Altering a person's unhelpful thinking can lead to healthier behaviors and improved emotion regulation. So, in CBT, we're encouraging patients to reevaluate and identify unhelpful thinking patterns or distortions. Addressing negative patterns like overgeneralization, catastrophic thinking, and diminished positive thinking, all of these maladaptive thinking patterns. So, promoting balanced and effective thinking to improve coping and reconceptualization of the trauma and self-understanding. So, trauma focus techniques include controlled exposure to trauma, narratives, or reminders to reduce avoidance and maladaptive association, so those thinking patterns. Exposure is collaboratively planned, allowing the patient to choose their approach. So it's very patient-centered, hopefully allowing the patient to feel autonomy in their decision and their recovery through this therapy. Goals of the technique include restoring a sense of control, self-confidence, and predictability. Also to reduce those escape or avoidance behaviors, kind of through that exposure angle. Okay, CPT. So we have cognitive processing therapy. This is a specific type of CBT that helps modify perceptions and beliefs about their trauma. So a patient creates a new understanding and conceptualization of the traumatic event, therefore reducing ongoing negative effects of the trauma on their current life. So treatment begins with psychoeducation, explaining PTSD thoughts and emotions to the patient, helping the patient recognize the relationship between thoughts and emotions. Um, so identifying those automatic thoughts, as I was describing on the last slide, those overgeneralizations, catastrophic thinking, those kinds of thoughts, which are contributing to their PTSD symptoms. Patient rights and impact statement, exploring the events, causes, and effects on their beliefs about self, others, and the world. So formal trauma processing looks like patient writing a detailed account of their worst traumatic experience. The account is read in a session to reduce avoidance. So here's the exposure angle of the trauma-related thoughts and feelings. So then the therapist uses Socratic questioning to challenge those unhelpful thoughts. So, such as self-blame, to reshape that maladaptive thinking. So using specific questioning to highlight the flawed angles of those thoughts. Okay. Developing and applying those adaptive strategies. Patients learn to evaluate and modify trauma-related beliefs using these new skills. Focus on areas including safety, trust, power, control, esteem, and intimacy, which directly impact or may be impacting their PTSD symptoms. Therapists encourage use of skills outside of treatment to reduce symptoms. So this is not just within the therapy, it's encouraged to be used outside of therapy. So can be provided individually or within structured group sessions, includes those out of class, or sorry, out of session practice assignments. CPT may or may not include the written trauma account. I think that it's used sometimes, but not always. Some versions just focus more on those cognitive techniques, those skills to reshift and um, reframe how people are thinking and in relation to those traumatic memories. Okay, third, we have cognitive therapy. So this is another form of CBT that works to modify a patient's negative self-evaluations and memories of the trauma. Cognitive therapy is goal-oriented, with the goal is to change negative thoughts. So those maladaptive thinking behaviors, we're seeing that again. This can be done by interrupting or disrupting those disturbing thoughts, replacing them with more realistic, positive thoughts, and learn to distance themselves from those thinking patterns or those thoughts. Um, so, purpose of the treatment, modify those pessimistic evaluations and trauma memories to disrupt patterns that are directly or are interfering with their daily life. Okay, key steps in therapy. Identifying those triggers and appraisals. So understanding the meanings behind trauma and those behind traumatic memories and recognizing exaggerated feelings of threat. So recognizing that they are no longer living within that trauma, hopefully in most cases, and that they are safe or are no longer threatened. Using Socratic questioning and other techniques to create compelling new evaluation. So through questioning, we had that in CPT as well, that Socratic questioning. So using that as a technique to create compelling new evaluations, hopefully restructuring the way that patients are thinking and thinking differently to use more positive thinking. Um, so, oops, sorry. Um, Also building a narrative account. So we saw that in the CPT as well, but developing a meaningful story of trauma from before the event to post-recovery, using methods like writing, reliving the event, and revisiting the trauma. Maybe we don't have that personal account narrative here, but we're still using some other tools to think about the event. Identify and restructure memories, points that trigger strong responses. So figuring out what those specific trauma responses are and identifying them and working with them. Further, just addressing unhelpful behaviors and thoughts, target rumination, safety-seeking behaviors, and thought suppression or avoidance, highlighting how these strategies sustain PTSD and disrupt daily life. So really like creating that therapist patient understanding of how these thought patterns are affecting their daily life. Okay, last of the four APA recommended treatments, we have prolonged exposure therapy. So CBT, it's another form of CBT that helps clients gradually approach trauma-related memories, feelings, and situations. Um, Helps patient learn that their memories and traumas are no longer dangerous. It involves gradually approaching trauma-related memories, feelings, and situations that a patient has been avoiding, therefore reinforcing that response to these memories and reminders of the initial trauma. So, initial steps. Overview of treatment and exploration of the patient's past experiences, psychoeducation. So we see that angle of psychoeducation of allowing the patient to understand what anxiety management techniques look like, and also incorporating some techniques that they could use, such as breathing exercises. Okay, now we have the exposure therapy aspect of it. So this begins after assessment and initial sessions, which create that safe and supportive environment between the therapist and patient. Okay, then we have imaginal exposure. So this is how we're seeing that exposure angle come in. imaginal exposure conducted in sessions with patient, describing the traumatic event in detail and in present tense, so as if they are reliving it. Any emotions that are raised within this setting are processed with the therapist. Sessions recordings sessions are recorded and are used for homework to reinforce processing and coping skills. Also, we have in vivo exposure, confronting feared stimuli, situations outside of therapy. So, not avoiding certain things because they remind the individual of their traumatic memory. Um, Further, therapists and patients identify the stimuli and plan exposure in gradual and manageable ways so that the patient doesn't become overwhelmed. Um, there's also outside homework, focusing on building confidence and emotional coping through successful exposure. Okay. Um, so these are conditionally recommended on contextual differences. So this is where I'm bringing in some pieces that are maybe more effective for refugees or considered in more extreme cases, such as the refugee population. So we have narrative exposure therapy. Narrative exposure therapy is kind of similar to prolonged exposure, like I just discussed. It aids in the integration, similar to prolonged exposure. So it starts out with education about PTSD symptoms and the need to face the traumas. So this is the exposure angle, helping the client to narrate and relive the traumas in detail with accompanying sensations and feelings, imaginal exposure, and reframing the perceptions of a victim's role into a survivor's role. So kind of rewriting the narrative that that person is experiencing. So NET treats trauma disorders, especially complex or multiple traumas, such as we see in the refugee population. It's often used in community settings for individuals affected by political, cultural, or social traumas, e.g., refugees. Um, it's delivered in 4 to 10 sessions, either in small groups or individually, helps patients reframe their life story, moving beyond trauma-focused narratives to reduce distress. Conditionally recommended for PTSD treatment. So the core principles of NET include patients creating a chronological life narrative, which focuses on traumatic and positive experiences, contextualizing these fragmented traumatic memories into like a more coherent autobiographical story. This strengthens cognitive and emotional sensory integration of those traumatic memories. So the therapist's role here is to demonstrate compassion and active listening, positive regard, and building that strong therapeutic patient-therapist alliance, guiding the patient through traumatic events while staying grounded in the present, using reminders to link emotions and physical responses to specific events and reprocess them with meaning. So understanding what actually happened. So outcomes of NET look like patients receiving documented autobiography created by the therapist. This biography reflects the patient's entire life and not just specific traumas, fostering personal identity and understanding. Further highlighting interconnections between experiences, emotions, behavior, aiding in that integration and healing. This also recognizes the patient's dignity and human rights, with the biography often serving as incentive to complete treatment. Um, so it's good. It's reinforcing and so that patients want to continue treatment. Okay, last of the treatments, I have EMDR. EMDR was developed based on the adaptive information processing model. It's delivered in 6 to 12 individual sessions, 1 to 2 times per week, with flexibility for fewer sessions or consecutive days. The theoretical basis of adaptive information processing is that the theory describes that PTSD symptoms stem from unprocessed traumatic memories containing emotions, thoughts, beliefs, and physical sensations. So these triggered memories lead to distress and associated symptoms. This unique approach focuses on changing how traumatic memories are stored in the brain rather than directly assessing the emotions, thoughts, and responses. So here we see kind of like a bigger gap or difference between like that those CBT models where we're evaluating it on thinking and how those thinking patterns influence the individual and their PTSD symptoms, and rather thinking of it as how these memories are actually stored and why that and how that affects PTSD. So aims to reduce and eliminate these symptoms by altering their memory storage. So therapeutic process involves standardized procedures, including bilateral stimulation, like eye movements, tones, or taps. Patients focus on trauma memories while experiencing that bilateral stimulation, which reduces the vividness and emotional intensity of that memory. Observations suggest EMDR accelerates the processing and integration of those traumatic experiences. Okay. Now we have medications that can be used for PTSD as a more biomedical approach. So we look mainly at the role of serotonin, which significantly influences mood and anxiety disorders. Its activity in the peripheral and central nervous systems can be modulated by these SSRIs. Serotonin is identified as helping with PTSD. So, two FDA approved options are sertraline and praxetine, and they're typically the first line medication for PTSD treatment. Individualized treatment could look like exceptions to SSRIs, which is dependent on side effects, response history, comorbidities, and patient preferences. Yeah. Other factors to consider are current stressors. Look back to my video on refugees' cultural context. So, therapists should understand past and current stressors that may be contributing and continually affecting the patient's recovery and treatment. Further, therapists and clients should work to have realistic expectations about treatment, with a focus not necessarily on complete relief of PTSD symptoms or symptom reduction overall, but in cases that are more difficult to treat, focusing on improving quality of life. Um, Other therapies may be considered in this case, in these difficult cases, such as acceptance and commitment therapy, which can help a patient come to terms with their more chronic symptoms that are difficult to treat. Yep, those are the clinical APA recommended guidelines, and this is how PTSD is seen to be treated.